Welcome to the Aging Well podcast. I'm Jeff Armstrong, here with Corbin Bruton. In this and the episodes that follow, we will share candid discussions on aging and hear from the experts. We are here to inform and encourage as we experience, well, aging. In this episode, I have the pleasure of speaking with Dr. Dan Dowhower, a colleague at Western Oregon University with a doctorate in public health from Oregon State University. Dr. Dowhower will be sharing his insights on how various social factors impact the health and well-being of the aging population. Stay tuned for an enlightening conversation on how to address these determinants and advocate for better health policies for aging well. Let's begin by having you tell the listeners a little bit about yourself, and feel free to share how wonderful it is to work with me.
Oh, well, of course. You're one of my favorite people. I enjoy it. You got good humor. So, Dan Dowhower, I'm an assistant professor at this point at Western Oregon University in public health. I have an interesting path because I've had a variety of careers, but I think the kind of commonality amongst the different jobs that I've had were really helping people become the best that they can be, whether it was in admissions, to find the best fit for university, to maximize one's kind of fit and ability to pursue their passions and their dreams, to now as a faculty member, really trying to engage a young population, our 19, 20, 21-year-olds, to really start thinking about the world that they want to age into, right? Because where there's a huge disconnect for many of our students that when we were talking before we started this podcast, we were talking about how the age pyramid is inverting, right? And so by 2060, the vast majority of people are going to be in their 60s rather than, the base at the bottom being young. We're not producing at the same rate that we once were in terms of birthing new children. But what was very interesting is in my class, I asked them, so who do you think those people are? And they're like, I don't know. And I said, they're you. You are those people who are going to be 60. And so you need to be engaged in understanding your world and the way that, your environment is set up, the way that we look at education and economics and neighborhood and built environment, like we're talking about, like the social and community context, because as we're getting older, right, we start losing friends and family. That's just the nature of things. So what does that connection look like? And how do we maintain that so that we have what the World Health Organization talks about is a complete state of physical, mental, and social well-being? I think we often focus on trying to prevent disease or getting sick. But what we don't do in the preventative or the proactive way is think, well, what can we do so that we can maximize health as long as we can maximize health? So that's kind of where my trajectory career-wise has always been. It's always been in higher ed, but really working with students to begin to get them to think about why it's important to vote, why it's important to express the opinion, and why it's important to think about laws and policies and all of those things, because there's so many where I always joke, can't see it from my house. Well, not now, but one day it will be seen from your house. And what is that house you want to be in, right? What is that world you want to create for yourself? I don't know if that answers your question. I just kind of went on.
Oh, I have many more questions for you. So the podcast isn't over yet, but it kind of, it really underscores a lot of what we talk about on the podcast. I like how you used the phrase proactive. And we talk a lot about healthcare being more reactive anymore. And we wait for people to get sick before we do anything, and then we treat them, and it costs so much more, and it's such a huge expense to our communities. And we don't do the things that are more proactive in allowing people to age successfully, to age with good health. And I know one of your most popular courses that you teach is the Social Determinants of Health. And I know you teach many popular classes, but that's one I really kind of want to focus a little bit on today. Can you briefly explain what are social determinants of health and why are they important?
Well, social determinants of health are basically all those non-medical factors that can affect a person's health and quality of life and their ability to function. So they're generally by the CDC grouped into 5 areas. There's economic stability. So we're looking at employment, job security, retirement. What does that look like? Education, access, and quality. I often tell my students in this class that all we promise you in the United States is a free public education. We do not promise that it's equal or equitable across ways. And you can see that by the way that our education is funded by taxes. So if you live in a high income, high tax area, your education is going to be better than someone who doesn't. We look at healthcare access and quality, and this gets oversimplified a lot because people think, you just need a clinic in your community. No, you can build it. But if a person can't get there, if they can't afford to get there, so when we talk about healthcare access and quality, it also means the ability to get it and to pay for it and not go broke, but also recognizing that it's not a one-stop, all fits one person stop kind of thing, that for you and I as older gentlemen, our needs are going to be different than someone who's 18 or 19, right? And we often shoot down the middle, I think, a lot when we think about that. But the neighborhood and the built environment that we were talking about, none of our communities, there's a very few areas where we really plan for lifelong living, that you can see this whole suburban sprawl. Many of these people might live 25 minutes, 30 plus minutes from the city center or any kind of shopping, whatever it might be. And as you get older, mobility and being able to take advantage of that, right, is going to be quite difficult. But then also successfully aging is made hard, because when you relocate to get into some of these services, kind of related to healthcare, when we talk about aging services, they're really expensive. I mean, really expensive. And we are seeing more that two age groups are the poorest in our nation, are kids like under 5 or children, and the aged, because we don't have an infrastructure that allows them to be able to live. Right now, if you want to retire, they're saying something to the effect of $1.5 million plus dollars is what you will need. And so when we start looking at policies that are limiting Medicare, Medicaid, Social Security, that makes that kind of a hard thing. But then also built environment, like green space, right? That when I lived in Chicago, it was all buildings, right? And when it got hot, right? Because nothing absorbed. So there are actually communities around the world that are really planting trees again. For example, I was just in Lausanne, Switzerland, and they are actively removing concrete and planting trees and grass because they need to control climate and control temperatures. It's just getting too hot because everything's like, you can fry an egg on it when it gets warm. But then the social and community context. What do we got going on? We focus everything almost on our work lives. But when we think about, the summers off from school for kids or post-retirement, there really aren't a lot of things that continue to keep people engaged. Earlier, before we started, you push the start button, you were talking about how do we get kids to engage elderly and elderly to engage kids. And that's a really beneficial relationship, right? And, but we continue to separate them. We don't allow that time for them to come together, as an example. And it there are a variety of opportunities one can take. So it's kind of those 5 that we talk about all of the time. And it doesn't mean if they exist that I can guarantee that you will take advantage of it and your life will be better. But what we do know is when we are proactively thinking about these things and collaborating with other entities, be it the government or construction or, the economic structures that might be, that we can reduce kind of the collateral damage of forgetting some of these aspects.
So what led you to focus on social determinants of health in your career research?
Well, I think for me, that there's a difference between social determinants of health and social need, right? And I feel like we do all of this focus on social need. Oh, Jeff, you need to eat more healthy vegetables, and we're seeing that as you're aging, this is happening to you. So how can we help you be able to afford, or so we can think of community gardens or giving you money to go buy some more and those kinds of things. But the reality is your health as it relates to nutritional value started back prenatally, right? So we're addressing the symptoms rather than the cause. And addressing the symptom is important. But I think what happens is that if I say, okay, Jeff, I talked to the local WinCo and they're going to reduce the cost of organics for people over the age of 60. And on Tuesday, she'll get an additional 25% off. It doesn't mean you'll take advantage of it. Or if you do that, you even know what to do with this. Or more importantly, that you live someplace where you can maintain organic vegetables in your home. You may not have the refrigerator, so we have to think more, because then what'll happen is people say, well, Jeff's not doing anything. We told him he could buy these organic vegetables and he's just not doing it. So he's not invested in himself. He doesn't take responsibility for himself. And so therefore Jeff doesn't deserve help. And if we think that, we can apply that to so many situations in the United States. When we talk about exercise science, you have some of these folks that would love to be able to exercise, but their built environment doesn't support it. And when we talk about the built environment, we talk about safety, lit, green space. Are there even sidewalks? Do you have to run in the street? You just have to go to some different areas. And you can
we talk about that a lot in exercise science. It's like, you look at the statistics, half of Americans aren't even exercising at all. And I think it's almost 3/4 that aren't meeting the minimum physical activity guidelines. Well, it's easy to sit back and say, well, Americans are just fat and lazy and they're not doing what they need to be doing. But the reality is there are so many barriers and obstacles that we don't address. And if we start addressing those barriers and we start knocking them down, there's going to be people that are like, I don't care, I'm still not going to do it. But that's their problem, right? But the people that really want to be engaged in exercise and healthy practices, we got to give them the opportunities to do it, to make the choice, to make the right decision.
Or we just make it even easier than that, right?
Yeah.
That we just make it part of their life. Like, I can guarantee you that when you and I were kids and we were in elementary school, we had recess and we had gym. And the two things were very different, right? But now, if you look at schools today, in terms of cost cutting and those kinds of things, they eliminate gym and they figure recess is gym. In fact, as an example, our kids went to a school where they had to bring home a slip of paper that then we had to document as parents, saying that every day they got 30 minutes of exercise outside of the house. And we're like, but why don't they have gym class? I mean, I appreciate that, but they're not seeing that as part of their learning and life balance, self-education process, right? So really, for me, when I think about what we're talking about here, is that the social expectation that we have such poor work-life balance in the United States. Work is more important, and you sit in front of your desk and you do whatever it is that you need to do and you get it done, and everything else comes second to that. If you go to many European countries, they're like, geez, you people are driving yourself into the grave. And we're just as productive, and we have work-life balance. We have policies that on Sunday, you can't mow your lawn because you are not going to work. You are going to relax, right? But on Sunday, you and I are probably grading papers and working because we need to keep ahead because because there's just so many demands. And it's an interesting thing. That is a social determinant of health, work-life balance. And if we don't fix it, we're not going to get any better. And then, of course, we can connect it to the obesity pandemic, right?
Yeah.
Which is something you're fighting with.
Now, I don't grade on Sundays if I can help it. I do try and take one day off from work. But again, that comes back to some of the social determinants of health, that I have that opportunity. I don't have to work. I mean, in academia, I heard years ago that, academia is great. You get to pick the 80 hours you work a week, right? Well, we do probably work extra hours than, most, and we should take more recreation time. And I try to do that. I mean, I wouldn't be living the Aging Well podcast if I didn't try and do some of that. And I say no a little bit more often. But there are those people that they don't have that opportunity to say no. I have to work 6-7 days a week.
For that. Yeah. It's interesting. Here's another example of like a work policy, right? So I'm just going to say, I know a person who works at a gas station. And when we had this heat thing the last few weeks, that unless it hit 100 degrees, they could not go inside to the air conditioning. So if it was 99 degrees, they still had to stand outside. Right? Isn't that
crazy?
Strangest policy? Because what I'm thinking to myself is, but they didn't provide water. There was no bottled water. And what bottled water they had was stored outside because they didn't have room in the kiosk, right? So these are the things that I talk about, right? When we're saying, okay, people are dying at work from heat exhaustion. And we're saying, well, it has to be 100 degrees. Let's back up a little bit. Let's go back upstream and say, okay, what's the problem with this? And how can we make it more likely to be successful, right? And there are different solutions that I could think of, even if they provided the neck air conditioners, right? So these people at least had a chance, or cold water, or other things. There's a variety of things rather than kind of this penal approach to everything, right?
Yeah, so what are some of the key concepts or topics that you cover in your social determinants of health courses?
Well, I talk about, I come from the perspective of health disparities, right? So what happens is that people's kind of exposure or access, if you will, to these kind of determinants of health, or what the context of their life really looks like, because social determinants of health aren't necessarily negative or positive, right? That there are some that might counter health and others that approach health. So even in a situation where you have both, the idea is how do we minimize and leverage, right? But so everything I talk about is from the perspective of how do we create health equity or reduce health inequities or health disparities. So I look at issues around like demographic stuff, age, gender, race, sexual orientation, disability or ability status. We look at food deserts, built environment, education, income inequality, and a variety of those kinds of things. And then as we're going through the class, I've got it set up in a way that I start layering. So, okay, so you're a Black, gay, male living in the United States. How are social determinants of health, like policies and laws and neighborhoods, what is it that looks like more likely for you? What is your educational experience? And so what you start seeing is, I'm very careful about using the term intersectionality because it's really within race. But when you start looking at how individually some of these things can put you in a position of disparity, that when you start looking at the intersection or the layering of many of these things, so we try to flesh out, well, then what do, right? Because we look at the socio-ecologic model where we have individual, interpersonal, organizational, community, and then like policy and law. So how are we working across all these different social levels to allow a person to maximize their health, right? So that group I just mentioned, we just have to look at the United States in the last 8 years, right? We see efforts to ban books that involve anything that has Black history, sexual orientation differences, or a particular orientation. We are looking at just a variety of things around policies and laws around how we look at people who don't look like the majority, how they get treated. So when we start looking at that, the real issue is I bring it back to stress, right? Your cortisol levels are going to be very different. And that affects not only the quality of your life from birth on, but even in your reproductive cycle. We see there's intergenerational transmission of many of these things that you start seeing your telomeres are shortening. And then it happens that's what then gets passed along. So there's an intergenerational piece. So I really look at all of these kinds of intersections and past, present, future, really trying to get students to kind of flesh that out rather than just saying, oh, here's the problem today. Check. We took care of that problem, but you didn't. You didn't. What you did is you made whomever was present at that time better, but it's only for that slice in time. Eventually, they've got to go to the next developmental period in their life. And have we thought about that? Does that make sense?
Yeah, it makes perfect sense. I mean, there's so many different directions to go from all that. Can you discuss any
thing, right? It's a really big thing. And I always say to the students, I know it can be really overwhelming, but what you have to think about is, all right, can I pick a really hot topic? Abortion. Okay. If people no, we cannot have abortion. And I always say to my students, and this is true, your opinion is your opinion. What you think about abortion is fine or not fine. I don't care. But if we don't want abortion to be the go-to as we think of it, then what is it that we have to think about? Abortion is just a symptom. So when we start going back, what we also start seeing that we're doing in the United States is we're not teaching about sex ed. We are avoiding any topics about orientation or differences. We are allowing insurances to limit or not support reproductive rights, particularly for women. We have overturned Roe versus Wade. We are telling women that they have to have their children while simultaneously cutting all of the programs that would support those women who are having babies, right? And so what we're trying to do is eliminate this one piece actually during a time in the U.S. history where we are at an all-time low of people seeking abortions. So it wasn't even technically an issue. It's just something that gets fervor. But if this is truly what we want to see not happen, don't outlaw this. Come back over here and say, we're going to teach you as much as we know and as much as you need to know and do it accurately and scientifically. If you compare us to countries that have that kind of education, you will see that abortion is much lower than it is here. But also the sexual debut of Americans is usually around 17. In many of these countries that have much better sex ed and preparation, it's 21. So we're trying to prevent people from doing something by not talking about it. But when we look at the evidence where people talk about it, we actually see that them not doing it works. They postpone it, and so when we talk about those social determinants of health and the idea of health disparities and those kinds of things, that's the way you have to start thinking about it, right? I say treat everything like a symptom. Aging is a symptom. Unhealthy aging is a symptom. What do we need to do to reduce the years we live in disability? Because if we look at the way we live life, we're like going great, we're going great, and then we start disability, death, right? We live a long time in disability in the United States. Our preferred one is you get up there, you're doing great, boom, you're done.
Yeah.
Done. And in order to do that, we have to look at many of those things that we just talked about, because it makes a difference.
Yeah, we often talk in terms of the 4 ages. Was that Peter Laster?
Mm-hmm.
I think that came up with that. And I know, Margaret Manugian, one of our colleagues in gerontology. We had her on. She actually did 3 episodes with me because we talked so long. But
she's fantastic.
She says, gerontology, I don't necessarily favor that language as much, but I like it from the standpoint it does look at some of those, those areas where we need to focus. You have first age, is that age of development. What are we doing, not doing during the period of development that's going to impact that next age, which is where we're now able to be productive or not able to be productive, and kind of create the environment, the finances, and the health that we need to get into that third age where now, which I'm not a big proponent of retirement. I don't plan on retiring. I might be at Western longer than you. Who knows? But I can't see myself stopping and not doing something, So if it's not teaching, I'm going to be doing something. But my goal is for that third age to be as long as possible where I'm living, maybe beyond my career. I'm able to do other things. I can live financially well, live in good health. I don't even say relatively good health. I want to say absolute good health. I want to be, and I tell my students, I say, when I go back to my high school reunions, I always want to be in proportionally better shape and health than everybody else. And it's really not that hard if you just simply maintain a high level of functionality and health. And because everybody else is tending to decline much more rapidly. No diss to my classmates. In fact, many of my classmates are doing extremely well as well, which makes that competition a little bit harder. But when I get to fourth age should be a matter of days for most of us.
Right. Well, you said something really important, is that, that this is something that you're doing, and you and I are in a really great place that we're able to do that. Right. I know plenty of folks that are really blue collar workers, for example, and they work in industries where the work environment, I can look at my own siblings, right? That the cleanliness and the quality of the work environment is variable. The kind of hours they have to work, when they have to work, the physical toll it's taken on their body because they're standing for 10 hours straight, lifting things and moving things, and it's hot and there's a lot of bad air, and so that, and then they only get 2 weeks of vacation a year, right? But then there's mandatory overtime, right? So that you and I don't have that, right? And so for some of my siblings to be able to finally take care of themselves is at retirement.
Yeah.
I can finally do something. I can finally make time to go to the gym. I can finally be consistent with some of these things. I can finally start living a balanced life, because that 40+ hour work week where I'm working in a mill or whatever that looks like is now done. We don't permit people who are in these very structured and kind of industrial, for example, factory settings, they don't get the same thing, you know. They don't even get an hour lunch sometimes, right? You know, and here's an example. We do that in our schools. What do we know about eating? Should you shove food down your throat in 15 minutes so that then you have 15 minutes to play outside? No, right? So, you know, or even the way that we're looking at how we create healthy thinking young adults or teenagers, right? If we were really, really invested in education of teenagers, all of their school days, like their high school days in particular, would start at 10. We start them at 7:30. We disrupt the kind of sleep that they need because of where their bodies are. We are completely ignoring their biodevelopment, you know, because we want to have school from 7:30 to 3:00. And it really should be maybe 10 to 5 or whatever hours that looks like. So, you know, we're not thinking through those kinds of things.
It's too easy to think things through, right?
Right. And it, you know, and a lot of people, I think there's going to have to be a lot of upfront strategy. There's going to be some cost associated with it. But I really believe that the early investments are going to pay off, right? Just think about economics. When we were first starting our jobs, when we were 18 or whatever, my parents had always put $20 away. Always at least put $20 away, whatever, because, you know, it was a part-time job, blah, blah, blah. And I did. And over time, that bank got bigger. So that when I was in school or going to grad, and if there was something I wanted, then now suddenly I started learning fiscal responsibilities, independent kind of things, the importance of, you know, savings and planning and taking care of my future so that when I needed it, I had it, right? It's no different. We can look at the physical well-being in the same way. You know, how do we bank savings, if you will, on our physical and emotional and spiritual well-being?
Yeah, I'm trying to think where to go with that. I mean, there's just, I just think of the expenses of not doing those things. You know, we think it's so expensive to, you know, pay for education, or it's so expensive to, you know, build a gym community center.
Yeah.
But we don't look at how much are we spending on healthcare? How much is obesity costing this nation in the trillions of dollars?
We do more secondary, tertiary, and I always mess up the quaternary intervention. We only, of our entire budget, which is huge, we only put less than, I think, maybe 1% into preventative healthcare. You're not rewarded for being proactive. You know, we teach Americans you go to the doctor when you're sick. Yeah. You don't worry about your health until you don't have it, right? And we hear multiple stories too that when a person's trying to advocate, that they're like, "Look, you don't need this. Just go away." And then you hear those stories where they really were in tune with their body, but we westernized medicine, said, you know, we didn't see anything, so therefore it does not exist, right? And and so then we are training our citizens, I think, to not be healthy, to not think about being healthy, to not be proactive, right?
And I think there's a certain expectation anymore that we are going to not be healthy because that's the norm. You know, it's like it's normal when you sit in your 60s to start having heart conditions and high blood pressure and obesity and all that. It's not normal. It's just the normal for our population. And so when you compare yourself against the norms, okay, yeah, I'm doing pretty well. You know, I teach my exercise testing and prescription class. You know, we go through some of the norms for physical performance, and I'll show them, here's the categories for one repetition maximum on the bench press. If I'm in my 20s and I can bench my body weight, I'm in bare condition. At 60, if I can bench my body weight, which I still can, I'm like superhuman. And it's like, that shouldn't be the case.
Right.
I mean, yeah, there could be a decline in health and fitness, but we shouldn't be looking at getting in worse shape, becoming a better and better category. Same with like VO2 max. My
Right.
VO2 max is still in the exceptional category, even though I've probably lost about 15 points over the last couple decades.
Yeah, no. And again, that the career, the life choice, not life, the career and the options that you had before you to be able to maintain that are not equal across all human beings. And I think that we love to blame the individual for how they become who they become, right? So I'm not saying that people don't have accountability, that people, this is one of the things. I'll do it this way. In my class, I always say, okay, we like to assume that everybody has the full breadth of options in front of them. All right. But is it true? So when we start thinking about social determinants of health, okay, not everybody lives in the great education tax base. So now they kind of have these options. And then others are like living in maybe rural areas that have less access to healthcare. So now they are among these options, right? And then we start looking at these food deserts where the closest store is a convenience store or a grocery store that doesn't have, fresh vegetables. They might have some, but, a lot of people rely on canned vegetables as an example. So now we're down to here. So what we're seeing is a lot of the decisions we think people are making are really, they're trying to do the best amongst the worst choices that they have, right? And I think that we don't think about it that way, right? We love to say, no, it's your fault. You did this to yourself. My parents were both blue collar workers, right? And when I was growing up, we were poor. So those 25-cent pizzas were often our meals because we could afford that.
Yeah.
And or that soda was cheaper than juice. So that's what we could have as a treat, right? I can remember like begging for grapes and cantaloupe. And my dad said, I'm sorry, guy, it's just too expensive. We can't afford it. So I would save up my money and go buy it from allowances. I'd get like $1 a week, right? And so that's the stuff that resonates in the back of my mind. Who you see before you today. Yeah, I got multiple degrees. I'm faculty. But my roots, if you look at the history and what I was working with early on in life, I'm an exception rather than the rule.
Yeah.
And that's just what people think, when we look at, we've got an Oprah Winfrey and we've got a Barack Obama. No, those are exceptions. In fact, the fact that we say that they're exceptions. These are exceptional moments. But not everybody gets that moment because they have a very different context that they have to live in and survive and create what they think are healthy responses to those things, right?
And I think that's an issue too, is that we don't necessarily teach what are those healthy decisions within the parameters that we find ourselves so that we can better the situations.
Right.
Like you mentioned, decision between pop and soda. I call it pop, by the way. I'm from Pittsburgh. It's pop. I have that argument with my wife all the time. But, the choice between soda and juice, I would argue, and again, it's because the benefit of my education, that both are bad choices, and let's move to something healthier like water or, even milk that might have some protein to it.
But the Florida orange juice industry was telling everybody, the milk industry was telling everybody, do you know how much milk you would have to drink to get the level of vitamin D required on a daily basis?
Yeah.
And we allow the milk industry to do their own research. So So it's funded by people who are invested in people wanting people to buy milk. You can't drink enough milk, right? So it's even the information that we're producing, right? That people are hearing, that there's no really strong vetting of that information, right? We're told, and it's even worse now that we kind of allowed this rogue kind of sense of reporting of outcomes of different things, that one day they're like, take vitamin D. The next day it's like, wait a minute, what do you mean it causes cancer? No, that was the wrong thing. That was vitamin D3 with something, right? And we are not vetting the information so that people who all started out with having less health literacy can make the best decisions for themselves. We don't do that for human beings in the United States.
True. So what role do social support networks play in health and well-being of older adults?
They're huge. The thing is that as we are aging, we had mentioned this earlier, that, our friendship circles start to reduce. I mean, my friendship circles are already getting smaller because we're carrying more work and doing other kinds of things. But the social network and the social connections are really critical for mental well-being and also physical well-being, right? Do you have friends that you can walk with? Do you have friends that you can have go coffee with? Do you have family that you can rely on in the event of an emergency? Is there someone who can stay with you if you get your hip replaced, or do we have to stick you into a nursing home, right? So the idea is that if we really think about social support, social connection, and community, it really promotes not only a sense of security, like that real basic kind of thing, and safety, but also this idea of people know you, you're valuable, you can reach out, you can feel comfortable knowing that you have someone you can turn to. And we don't see with many of our built communities, like I was saying, if you look to any of these suburbs around Portland, your neighbors, really not within screaming distance in some of them, right? So, it is that connection, right? We feel good. We're human beings. We need to do that. I think, one of the interesting outcomes of COVID, this is a perfect kind of example, is that when the students came back to the classroom, I don't know if you had this experience, but so many of them said, now I understand why I should sit in a class rather than doing it online. And it's not necessarily the knowledge. It's the fact that they can look other people in the face and they can see reaction and they can have conversations and they can laugh, right? But when you're on a screen of squares like the Brady Bunch, it doesn't happen. And so that was one thing for me that I still heard right through the end of spring quarter, that they're like, I'm so glad that this is an in-class class, not a online, because I really just need people. I need to be around people.
That's why all of my classes remain in person. I mean, I've switched a bit more of somewhat of a hybrid approach in terms of flipping the classes.
Yes.
But the purpose of flipping the class, giving them the content outside of class, they can watch my slides with recorded audio on them. Whether they do that or don't, I don't know, and I don't really control over that. But I expect them to be in the classroom. And I record my lectures so that it does give them some flexibility to, when, as Forrest Gump says, it happens. When this stuff happens in life, that they can miss class without feeling like they've missed a lot or something that they can't catch up on. But I really try and capitalize on this really increased need for engagement that I've noticed since COVID, where I've had the best engagement in classes since they've come back. Right. And I thrive in that environment because I think for me, it's social engagement as well. And I do better. They ask me a question that's not in the lecture notes, and I'm going to dive into my knowledge base, my understanding, feed off of you. And the learning is just so much better But a lot of it comes down to the fact that they're much more engaged now in the class rather than me just getting up there and pointing to a bunch of PowerPoint slides.
Yeah, I don't do that either. I just, but it's kind of like, even though we are online, I know that we have a relationship through work and stuff. But this whole thing is organic, right? We're really kind of probably going in directions that neither one of us thought we would be going. But I think these are really great opportunities for the kind of application of these concepts and constructs that we talk about, right? It's the one thing to say a person needs X, right? But if we don't vet out what X means and what can influence X's availability or that person's ability to access X, then we're not thinking about it. We're just saying, figure it out. It's on you. Yeah. And, I think that's it's an interesting mix, right?
And that's why, again, we go back to aging well begins basically perhaps before conception, but it definitely begins early in life, where the education, the social opportunities, the education of the parents, the food that you get, and even from the standpoint of, we talk a fair amount on here about epigenetics. And, in my PhysX class, I'll present the per Olaf Astrand quote that if you want to be an elite athlete, choose your parents wisely.
Exactly.
I come to the point where I say, no, it's actually more choose your grandparents wisely, and it's more than just the passing on genetics. There's certainly how the lifestyle of your grandparents has impacted the epigenetics of your parents and ultimately you, but how the nutrition that your mother got during pregnancy is going to have an effect, what kind of education they were able to have. All of these things impact who you are and what potential you have to become something better. But that doesn't mean that, we can say, well, I just blame my parents, my grandparents. I don't have to engage in my circumstances and try and move forward. But, we have a responsibility, I think, in our fields, in health and exercise science, this podcast, and just as people engaged in our communities, to address the opportunities and lack of opportunities that people have to make the right decisions, guide them to what is the right decision, and, just making each day better.
Right. I agree. And, and the thing too is that if we really want a world of elite athletes, that we need to interview those grandparents and we need to interview those parents and we need to say, so what did you need that you didn't get, right? Because we don't do prenatal care well. The United States has one of the worst maternal child death rates of any developed nation, and we spend more money than any of these nations per capita on medical things. And so, but it's because we don't make that free. We don't give people whose health insurance has such a high copay access to those kinds of pieces of information. We don't talk about it in our K through 8, K through 12 system. So like, I remember in ninth grade, my sex ed was the difference between boys and girls basically is internal and external plumbing. And I'm like, I think there might be more there, but, I had somebody who wasn't comfortable talking about it. They weren't vetted in it, and so my health literacy was a function of comfort, information, and a variety of things, beliefs, no, we shouldn't be teaching our children about that, right? And like, I even have students in my class say, why do we have to talk about sex? I'm like, well, we got to thank somebody for it, because you wouldn't be here talking about it if they didn't have it, right? And so it's normalizing the conversations too. We don't like sex and death in the United States. So anything that deals with it, we like to close our eyes and look away.
Yeah. And sex is part of aging well, I guess, too.
Right. And, old people have sex, right?
No way.
You know, I know it. I know it. I know it shocked the heck out of our kids. But
Yeah.
the thing though too is that, but we're not teaching. I think you and I had this conversation that we've created this lovely little blue pill called Viagra, right? Which was an accident because it's a blood pressure medication that had the interesting result of helping men who appropriately aged were having less erections or erectile dysfunction. But developmentally, that's appropriate, right? We're beyond those reproductive years. So what we did was like, well, we got to save those men and their erections. So we gave them that, but we didn't take into account that the female side of that for men who are having sex with women, that women's bodies change. They're dry and things are happening. So what we've done is in essence given a person a loaded gun to use without instruction because their sex ed was don't get pregnant with women who are probably not going to get pregnant, but they're going to have intercourse that might lead to more vaginal tearing. And this vaginal tearing then exposes women to STDs. We're seeing HIV rates among elderly women popping up a little bit because, ironically, it happened when we introduced Viagra, because we haven't taught these men that you still have to practice safer sex, right? So that's the collateral damage, because we also see that men die earlier than women. So the male to female ratio in aging is, and we're talking about the heterosexual kind of sexual activities, gives one guy more fish, so to speak, but we're not training them that no, you still have to be careful, right?
Yeah.
So that's social determinants of health, and that's health disparities, because then these elderly women go to a doctor who doesn't ask them if they're sexually active, because we assume, none of us are. And they present with, I've been sweating so bad at night and I'm feeling so tired during the day. Well, you're old. What do you think's going to happen? Well, they come back and they realize that what they had was HIV. And they've come back now with a diagnosis of AIDS because they have less B cells and T cells that are trained to help them at that age, so to speak. And it just makes for a much more costly maintenance fee for them, right? So we're not thinking holistically about, this idea of anything really: nutrition, sexual activity, physical activity, education, literacy, health literacy. Those are the things that matter. And I feel that, my voice is to always scream, don't forget about those things, because we need them if we want to age well, and we want to be healthy, and we want to reduce our years in disability. We need all of those things.
So when was the last time the leadership in the United States thought holistically? That kind of leads to my next question. What are policies or interventions do you believe are the most effective in addressing social determinants of health for the aging population? And by aging population, I think from birth to death.
Right.
So,
I think we have focused so much on the economics in our government, government intervention, too much government, too much cost, too little government, too little cost, right? That what we haven't really invested in is what is the cost benefits analysis of these eliminations and these reductions and the kinds of things that, right, we want to have happen. Like, as an example, we wanted to control alcohol, prohibition, right? Well, did people stop drinking? No. They went and they figured out how to drink. And then the government soon learned that their decision to enforce prohibition meant that they were getting less money. They were getting less taxes. And so that's why prohibition was overturned. because they're like, wait a minute, why should the crooks get the money? Let us get the money. We can tax people on their alcohol, the sin tax that we always talk about, cigarettes, those kinds of things. But the issue for me is that when we think about those policies, what we're not thinking about is, all right, we're going to lose that tax money. And so what is that tax money going to now lead to in terms of underfunding in different areas, right? So if we don't have sales tax or income tax or property tax, how are we going to support some of those infrastructures that we really need, right? We don't want taxes. People don't like to pay taxes, right? But I think we really have to step back and say, all right, if we really want national health care, which is going to be hard as all get out in the United States because it's so layered with pork belly and all kinds of good stuff like that. But if we really want to make that an option, what do we have to have? What are the common bases? How are we going to support these and then not messing with them and let them go, right? We're trying to get rid of Social Security. We're trying to reduce and eliminate Medicaid and Medicare. So that's not going to be great because we are thinking short term. We are not looking at the long range impact of a policy. And many of these policies, to be quite honest, take 15 years before we see their effect, And so really vetting them out and making good decisions that, requires us to think philosophically long term, not short term. So we have policies that'll work. I'm sure of it, right? If we don't continue to underfund education, right? If we try to figure out different ways of funding education. One of the things we see is that, it just flew out of my head, that we have so many corporations now that pay no taxes. They make no contribution, right? But they want to have us work for them. But they're not getting the best employees because back in the early 40s and 50s, we saw that corporate taxes really paid for educational infrastructure and fire and all of those other kinds of things, right? And now that we've eliminated that with Citizens United, that we've seen a complete inverse, that the majority of taxes are now paid by the individual, where 40, 50 years ago, it was the opposite of that. We actually got to keep more money, but now we can't keep money because we told the corporations they could act like individuals. So they can write off all of that. So companies like Amazon and Tesla don't pay taxes. They don't make a contribution. So I think we have to really think about, this fact that we're eliminating the middle class, that we're creating people who have lots and lots of money and people who don't. I don't know about you, but on my income, if I had to live alone, I could not live the life that I have right now.
I agree with you there. And we have a dual income, and we took a huge cut in pay moving from Michigan to here.
Yep.
And I still haven't recovered in my salary at Western Oregon University. So
I haven't recovered, and I moved here 18 years ago. And I have 2 master's degrees and a PhD, and there are teachers in the school systems here that are making more money than me, which is fine. I knew what I was getting into. I knew that I could do that given my relationship and that kind of stuff. But if I really were to be like, ooh, you know what? I got 2 kids. I'm going to be the primary earner. I would have to make hugely different decisions, So I don't know if that helped address the policy stuff. I just really think that, an individualistic society like the U.S. is going to struggle more, because we don't have the same kind of value of the collectivistic societies have. And it's neither good or bad, but we have to recognize, I think, that our culture is a determinant of our health. And what do we want to keep that leverages that health, and really what do we want to let go of, right? And it's across many, many levels.
That's why in my pathophysiology and exercise class, we take time each term to read and discuss a very old article, The Tragedy of the Commons by Gerhard Harding, from a perspective of healthcare and health, and talk about the role of universal health versus universal health care. And you know how in Oregon we've made it a constitutional change that everybody has the right to universal health care. Has anybody given any thought to what universal health care costs without doing the things that are going to help people to be more universally healthy?
Right.
We can't afford for people just to keep living unhealthy lifestyles and going to the doctor, going to the hospitals and being treated for it, because pharmaceuticals, surgical treatments, all those things cost tremendous amounts of money.
Yeah.
But again, as we've been talking about, there's those social determinants that make that more and more difficult for certain individuals. So what are we doing on that front end to make the changes in our society and change ourselves personally to be able to allow everybody access to aging well?
I think that we are finally seeing a shift where in the last, 5-8 years, we're really seeing a lot of focus on mental health and well-being. We are seeing, from the science side, this continued support and the expansion of really getting hospital systems and other medical systems and those of us who work in the public sector to recognize we need to start thinking differently about built environment and the kinds of recommendations that we make for somebody, right? So, like, if you were to come to me and I was a medical doctor, my conversations say, okay, look, you need to eat better and we need to get you to exercise more. Tell me, how does that work in your life? Tell me about your life. But often what we see is that dialogue doesn't take place, right? You're overweight. My doctor said to me when I first moved here, you need to lose weight. And I'm like, oh, okay, well, what do you have in mind? He said, I want you to lose 30 pounds. I'm like, how? I don't know how to lose 30 pounds. I mean, I'm exercising. I eat well. If my weight is not good for you, right now, I think I'm doing all the right stuff. I don't know what to do, right? And so he never had that conversation with me. We never talked about, mental health. I mean, when I moved here, I was way depressed, Jeff, way depressed. And I'm like, where did I move? Why did we move here, right? And because what I thought I was moving to versus what I moved to it was a 180. And so it did affect my mood, and it did affect how hard I exercised. And I did eat more Doritos and Hostess cupcakes, right? But part of it was I didn't have an outlet for my depression. I didn't have an outlet for things, right? And so it wasn't until I started saying to the doctor, because I advocate, like, okay, look, this is my reality. So then he helped me out. I got some pharmaceuticals and suddenly my world changed. And I was able to oh, right, now I can reset, right? But if I hadn't learned to advocate for myself, which is what health literacy permits you to do, then I would have been like, okay, so I'm eating well and I'm doing some exercise. Maybe I just need to eat less and exercise more, or not eat, do things in different ways. I mean, people get desperate. And if we're not having a good conversation, people will make the best decision given their circumstances. And it may be amongst, like I said, the worst of the best, the best of the worst.
And it really depends who's informing those decisions. I mean, I really hate going to doctors because I feel like a lot of times I know more than them. And my grandfather always said, I'm not a real doctor because I don't have I have a PhD. I don't have an MD. I can't prescribe medicine.
Right.
But, unfortunately, I finally have found a doctor who listens to me, and he understands that, okay, I know there are other approaches to this. Like when I had high cholesterol and when my blood gets tested, it always seems to happen on a week where my wife feeds me a ton of red meat. And so my cholesterol is always a little bit higher, and it sometimes tends to be a little bit higher. But at least he recognized that my HDLs are really, really good. My balance was there. I still needed to probably work on some stuff. And, at that time, and I'm kind of back that same position now where my fat weight has crept up a little bit just because COVID was great for me for getting in shape because I had plenty of free time. But, so he recognized I was trying to lose some weight. And, it's like before we start talking about statins, because it's like, there's no way you're going to prescribe a drug to me. There are physiological things that I can change that will improve my health. And so it's like, allow me to kind of focus on that. So he was at least well enough informed to be able to listen to that. But a lot of doctors, they don't get nutrition in medical school. They don't exercise. They don't understand exercise. Many of them are still on this kick, cardio, do more cardio. You got to lose weight, do more cardio. It's like, no, really, our better understanding now is you need to probably lift some more weights, and they don't know how to lift weights, so they can't give that instruction. What's that?
But muscle weighs more, right? So like for me, I'm like, I know maybe I could do like a little 10-pound thing here, but like I'm benching and I'm doing these things that like, I don't know. I don't know what else to do.
We get on this kick too about weight, and BMI. BMI is the biggest load of bullshit that we've ever been fed. And, I hate even talking about it in class.
Oh my God. Our insurance refers to me as morbidly obese.
Yeah.
Now, you've seen me in person. I know that camera's put on 10 pounds. I don't think I'm morbidly obese.
No. Well, I mean, I'm definitely overweight, and I feel like I'm right where I want to be. I might want to be a little bit lower in body fat, but if my weight stays where it's at and it's lean, I'm good with that. And I tell people, you want to be at a little bit higher BMI. One thing that I noticed during COVID was I dove into a lot of the different literature and the research of what, how physical activity, body composition, all those things were affecting one's risk of contracting, getting sick, being hospitalized, being on a ventilator, all those types of things. There was a bit of an inverted U that showed up repeatedly in the literature where if you had too low of a BMI, you were at a slightly higher risk. So I looked at that as being either extremely under fat or under muscled, which we have a lot of people that think, oh, I'm in a great BMI. I'm in the 20 and low, high teens, low 20s, but they have no muscle mass. They're all just basically fat on bone. Mm-hmm. And then you have those that are well above 30 were at much higher risk. But in that middle, it looked like the base of most of those curves were always somewhere in the neighborhood between about 23 to about 26, 27 BMI. And so I teach my students, that sweet spot's going to be somewhere around 25, 26 BMI. That means you probably have an adequate amount of fat to, when you're older, you want to be able to cushion falls, so you don't want to be too lean, but you also want to have some muscle, and that muscle is going to carry some weight with it. Right. And so if you have...
Which is good for bones.
Yeah. And there was a study that came out of China recently, and I don't think we've done the podcast on it yet. We might have. I'm trying to remember, but they really looked at BMI versus waist circumference. And they actually found the greater health outcomes came from individuals who had a slightly higher BMI, but a lower waist circumference. So it's like, okay, well, that's basically saying you have a better lean body composition. Mm-hmm. And I don't know, there's so much that we can do in the health professions to educate people better on, this is what is healthy for you.
Right.
And again, everybody's a little bit different.
You have to make that decision. I think educators have to do that. What was very interesting when you were talking about this inverted U, that, we always talk to the extremes. And we're always going to have extremes. But what we need to start thinking about is, the part that's here in the bell. And when you were talking about that and like healthy aging and stuff, one of the things that clicked into my mind is one of my mentors does work on blood pressure. And as people get older, the doctors really try to maintain blood pressure of someone much younger. But the reality is that what her research was showing is that, as we get older, our veins become stiffer and we calcify a little bit, right? And that in order to oxygenate our extremities, we need higher blood pressure. So there's this real concern that we have somehow said, let's make everybody 30 years old or whatever age you have with perfect blood pressure, and not recognizing developmental stages again, right? When I'm older, I might need higher blood pressure because my body's older. This is no young spring chicken anymore, right? And so we're looking, I think, too, at this is like that extreme. How do we get everybody to be this perfect, right? And it isn't possible. And I think too that, when we talk about social determinants of health, this also informs media and it informs advertisement. One of the things I always say to the students in my class is that Cindy Crawford was once quoted as saying, "When I look at a magazine, I wish I was Cindy Crawford." Because they Photoshop, they create this kind of ideal that is completely unachievable. And yet we have all bought into that rather than saying, what is that distribution and where in that distribution can I live? And if I start to get start saying, whoa, let's see what's going on here, right? That's the stuff that I think when we think about health literacy and really teaching people to pay attention to. I mean, I've had friends that have gone on trips to Europe and they're like, I only had water and I ate wafer-thin crackers because I didn't want to gain weight. I'm like, are you kidding me?
Go to Europe and you're not going to eat all the fancy, wonderful foods you can eat there?
Yeah, yum, right? But we create this. So it really creates this extremism in many forms rather than that balance, the life balance. Like there's a sweet spot, right? You've used that term a lot. I've been in your class and you talk about that. And I really like that term because the sweet spot is an individual term. But from a population health perspective, we spell out the wiggle room of that sweet spot can range from here to here. And you should be okay. I can't promise you as an individual, but our sweet spots are like that, right?
Yeah.
I think that's a really great word.
Well, I'll try and use it more then. I can't hit the sweet spot when I golf, though. That's the hard part.
Oh, I'm giving up. I have better luck just throwing the golf ball. So
the way I score my golf game is, if I lose a ball, I'm 1 under. If I find a ball, I'm +1. So I almost always am under par.
Oh, man.
So what has been the most surprising or impactful thing you've learned about social determinants of health through your work?
This may be more of an opinion than fact, but I spend most of my life being stunned that people don't think about them. That there's not that, like when we were talking about abortion, that's the issue. But for me, all those social needs that we talk about are just symptoms, that there's something that led us here. So what led us here? And it's in the addressing of those things. And so I really feel like sometimes we, lose the baby with the bathwater, so to speak. And that this kind of puritanical and kind of penalizing approach that we sometimes take to health, ironically, in the United States. And it's just my opinion. So I think for me, the stunner of it all is that it really is a lot simpler than we make it. I think that that we have to really start thinking about culturally what we want the United States to be, right? That, there's this whole push for eliminating diversity, but really that diversity to me is really important. We have the Hispanic paradox where when people come from Mexico, the first generation are really, really healthy. The second generation is less healthy. And the third generation is American. So we could learn a lot from these cultures that could influence the way that we think about food, our relationship to food, our relationship to family, intergenerational households. They are non-existent for most traditional American families, right? That I really feel like we have so many answers that exist in all of these groups that come to the United States, but we ask them to put them away and mainstream in when in fact we could gild that lily and be really probably one of the healthiest nations in the world. Right?
We should be the healthiest nation in the world just because of the resources we have available and everything else. We have an episode coming up. We haven't recorded it yet, but I want to talk about the Nordic diet, which kind of comes on the short tails of the Mediterranean diet for health. And I look at why is the American diet considered such the unhealthy diet when we have the best access to food? I mean, we're sending food across the globe. We have, meats of all different types. I mean, we have best transportation, but from a local standpoint, we should be able to access things locally so much easier than any other country. Why are we the worst diet in the world?
We only, what do they say? That we only have 3 major food distributors in the U.S. So there's a bit of a monopoly situation going on here. And I know from my experience in Europe that in a community, like I was just in Paris, right? In this community, you could find a baker, a butcher, a grocery store, you could find a pharmacy, you could find all of these. But in many places, that's all in that megalithic store on one side of town that the bus doesn't go to. And I don't have bike trails to get there. And I don't own a car because I can't drive because I have such bad vision. There's a whole lot of stuff there. And like, how is it that I could get across Europe without ever needing a car? But to live here, I'm forced to have a car, which means I'm forced to have insurance, which means I'm forced to have all those payments that track to make all of that great food you talk about unavailable to me. I'm just using me as an example, right? So I don't have the resources to take advantage of those resources, right? I oftentimes will have students, they're like, oh, you know what? I have a charge card and I have all of these things, but I'm like, okay, well, let's do a budget. Let's really do a budget in class. And when the budget comes down to it, what they realize is that without parent support and without financial aid, they're toast. And even with all of those things, they are eating as unhealthy as anybody else. And so the thing that irks me is that people say, well, you just have to teach people. We teach the top 10% of the country, right? Like, how many people get college degrees?
I don't know. I'm sure it's few.
But I'm looking at a whole group of people who know better, but they can't do better. Why? Because they can't afford to do better.
I might take a little bit of argument against that because there are options. I do think education needs to be a little bit better in terms of food preparation and making the most with the access that we do have. When I lived in New York, first time I moved out there, I took a job that did not pay me near enough to be able to live there. And this, mind you, was in the late 80s, early 90s. But my food budget was about $25 a week.
Yeah.
And I ate extremely well. But, I didn't eat fancy stuff. I lived on carrots, eggs, oatmeal, and, maybe some pasta, ground beef, those types of things. But I got well-balanced meals because I understood, I knew what I needed to spend the money on. And it wasn't, oh, I'm going to go out, buy beer or buy chips and buy all the other stuff. These are the priority foods. And I don't think we've educated our students well enough in understanding that. And I think we also do the same injustice to people who have needs and are kind of falling under some of those Social Security nets that are, there to help them. But, and it's always irks me when I see videos or, news clips of people distributing food to the poor. And what's always sitting on the top of that big box of food today? A big loaf of white Wonder kind of bread. Not even Wonder bread, it's the cheaper Wonder bread, and why are we giving shitty food to people that are in need, right? Why can't we give them better tools and better materials to build a healthier diet? Right. And I think that's one of the big areas that we really need to focus on is, yes, we need to improve access, but we also need to give people better understanding of what to do when they do have that access.
Right. But they also have to be able to afford it. Sure. Thinking of I show this one video in my class. It's about a Native American tribe that lives in Arizona. And Arizona wanted to become the Arizona it is today with all of that lovely green space and all those golf courses and stuff. And in order to do that, the then president at the time said, look, what we can do is we can build a dam on the Gila River, and we can redirect that water to Phoenix and all of these, areas so that you can have this beautiful, lavish green gardens in a place where it is just not what it does. But when they did that, what they did is they cut off water to an Indian reservation that relied on the water as their primary source of irrigation and growing crops. And they were very successful at growing crops. And in the history of that Indian nation, there was only one recorded person with diabetes. When they rediverted this river and all of that dried up, they couldn't farm anymore. So the government gave them the things that you were just talking about. Food that wasn't part of their diet. It wasn't even anything that they ate. And now this same population that was once almost basically diabetes free has the highest diabetes rate of any group of people in the world. And it's because we didn't think about the consequence of killing their water supply, right? And they're poor. They lost their income. They lost everything that they could do to make money. So that's the stuff that I talk about, right? Yeah. That, great. I'm so happy that Southern California is as lush and green as it is, because it isn't supposed to look like that. But we've made that a priority. But in making that a priority, what we've done now is made what was once an available neighborhood unavailable. So we've forced relocations, and we have forced people to go to areas that are much less equipped to allow them employment, affordable employment, stuff that can support them, to get them into these things. We then create these social structures where we say you can use this money to buy food, but you cannot buy organic food. You cannot buy certain things, right? And so what we're in essence saying is that when you go to the grocery store, all you can buy is stuff with long shelf life. And my go-to is always Velveeta cheese, right? I grew up on Velveeta cheese. I hated Velveeta cheese because I was like, how is it that a cheese product can remain unrefrigerated for 10 years and still be good or whatever, this freaky little thing, and so that's the stuff that I think about, Jeff, when I think that, right. So, we can teach them these things, But if we're not working with the other aspects, they're still, but even the diet that you mentioned, pasta, a lot of carbs, that's not necessarily a good diet for some.
Well, I wasn't necessarily emphasizing the pasta. I probably would have emphasized more beans, rice, those types of things.
Yeah. And for many.
But the pasta is what they're giving them, so
Right.
that's the crap that they're giving them rather than, here's a week's worth of meat, and doesn't have to be great cuts of meat. Here's bags of beans, and legumes are cheap. And that's one of the core staples of the healthiest diets in the world. And, root vegetables, carrots.
Yeah.
Okay. Yeah. It's maybe not the most variety, but, you have certain local root type vegetables that are going to be much healthier than some of the crappier stuff we might be buying.
It's fun.
So what is the healthiest, most accessible foods that we can give people to give them that greater chance at health and longevity and aging well?
Exactly. Yeah. Because, during the COVID project, we gave out food boxes, and I opened that up, and I'm like, oh, wow. I feel a little unethical here, because I looked at the contents and I'm like, I wouldn't eat any of this, but thank God for the agencies that are given the pittance that they get, that they can collect these things together to give to people who don't have an option. Right. And so it's just how we value human life. I think that this is an interesting country that we live in, right? Life is really important unless you're old, you're poor, you're young, you start labeling all of these things, and I think we really need to step back and say, we have to make all of this work together in some way. But right now we are saying, and let's talk about the SNAP benefits, right? So on SNAP, you can only make so much money a year. If you make more than that money, then you lose SNAP. So some people are kind of stuck here because the job that they need is a job that will provide insurance, because in the United States, the predominant source of insurance is through employment. So they can get a job at Starbucks. They can get insurance, but they're only being paid minimum wage. They have insurance, but now they're making too much money. So now what happens? That disappears. And now they're stuck here like, I can't afford to feed I can't afford anything. I can't pay my rent. I can't feed. I can't. I have insurance, but I don't have anything else because I can't afford anything else. Right. And so there's this, I'm still amazed that the Equal Rights Amendment has not been passed. They don't believe that we should pay women equal wages. And it just went up here in 2020 or 2021? No. And when we look at the workforce of the future, it's going to be all of these folks that we're underpaying. So there's a lot that we have to consider. It's not just, Dan, you just need to make better choices at Fred Meyer.
Yeah.
I'm like, I can tell you, even on my pay, there are some things where I just walk past because I'm like, yeah, that's not happening today, Satan. I'm not paying $9.99 a pound for, whatever, or $9 or what is it, $4.99 a pound for a cantaloupe, and it's a 5-pound cantaloupe. Come on, that's $20, $25. I'm not going to do that.
Yeah.
For a cantaloupe. Think what I can do with that $25.
I'm not buying cantaloupe.
Huh?
I'm not buying cantaloupe.
Right.
But I look at too, weighing some of the, cost health benefits of some of those things too, which is again something that not everybody is capable of making those decisions or informed enough to make those decisions.
Right.
I shouldn't say they're not capable. They're capable, they're just not informed.
And I honestly think that if people had higher health literacy, then they would advocate more, and we would see a push to say, wait a minute, we deserve better. We're paying taxes and we're doing these things. Wait a minute. I think that education is so important for a variety of reasons, right? It can change economies. And if people are well versed, then they know what they can advocate for.
Yeah, you mentioned how important it is for that individual to get their health insurance. Well, the reason that health insurance is so important is because they're going to get sick and they need to be able to be treated. We don't think about how the more important thing is not getting sick.
Right.
And so what are we doing as a society to limit the risks of health issues and everything else? We're living longer because people are being kept alive longer from medications. The quality of life sucks. And you're spending more time needing care.
Yeah. The United States has actually lost years of life. The average has dropped from, 81, 82 to 79. And it has everything to do with our health.
Yeah.
Japan and all of these other countries are well into almost 90. And I think COVID is the quintessential example of how we think about health in our country. Was it that hard to wear a mask?
No.
But, our independence, was being, our civil rights were being violated. This isn't the first time that we've gone through something like this, right? And we certainly bellied up to the bar on those other occasions. Why this time? Why now? Because we were being fed lies. We weren't being given honest, health literate kind of reasons for doing it.
And from my perspective too, we also weren't being educated in the preventative things that we could do to make ourselves less susceptible to these diseases.
Yeah.
There were a reason why certain populations were at higher risk of COVID. It's because we didn't do all these things on the front end, and it's decades of bad decisions on the basis of us as individuals, but also primarily of our governments and our communities.
Right.
So
and I always say that we are our government. Isn't that what the United States is? The government of the people. But I think that that's something that we're going to have to really fight for because it's waning quickly. And I do. So, but it's just fascinating because I really think that there are people that believe they don't deserve good health.
Yeah.
And when you're told your entire life that you're undervalued or you're not as important or you don't belong or you don't deserve, at some point it seeps in, right? It starts to seep in. And that if you're not a strong person, that stuff can win too.
Yeah. So I got to ask you the question I ask of all my guests. Right. What are you doing personally to age well?
Oh, well, I'm drinking coffee. No, I'm drinking.
Coffee's fine. 2 cups of coffee is actually very good. And so is a limited amount of the red wine. But
I have worked really hard in life balance. I go to the gym every other day, and it's kind of a mix of cardio. And I use the machines because, rather than free weights, simply because I want to make sure that I'm doing the right form, and the machines help me do that. I cycle. I love riding a bike. I garden. I really, and not like vegetables, but I do vegetables too. But just gardening is really fun. Getting out in that dirt, forgetting about life. That's the kind of stuff I'm doing. I'm just really trying to be mindful of my stress and picking and choosing what is going to stress me out that There are some things that are decisions beyond my control. You and I work at a place where sometimes we kind of sit in the bleacher seats thinking, what's going on here, right?
That's probably 99% of my time.
But then thinking, all right, well, what can I do to support my own employment, but our division, thinking how can we gild the lily based on what resources we currently have? What can we do to maximize, rather than always kind of looking at the cup as half empty. I really work at the cup as half full. I really work on that very hard. Sometimes it's a challenge, as you know, right? Sometimes you're just like, shoot, why doesn't my maker come get me today?
I'm not ready for that.
Yeah. And I love humor. I really try to see the silver lining. I love laughing. So anything that I can do, and in our interactions, I think, you see, I just throw out quips every now and again or whatever, because it's just, look, balance. I need balance. I can't be this heavy for this long. So,
yeah. So how can our listeners connect with you, learn more about your work? Obviously, there's the department website. I don't know if you have any other personal website or social media, but anything you'd share with the listeners?
I actually don't. I deleted a lot of my social media because I found myself spending too much time in front of it. And but absolutely, you can get my email through Western Oregon University's website. I would be more than happy. I love to talk to folks. You get my phone number, give me a buzz. It's all good. Yeah. So those are kind of the traditional routes. But I'm an old dog. Neutral. Yeah.
Well, anything we've missed? Any questions for me?
No, I really appreciated this conversation. I think it was a lot of really neat kind of bebopping around, but I think, ultimately we just need to stop working in silos, and we need to start being more collaborative, because, my philosophy has always been, in raising all of us, right? When we think about something that benefits all of us, it raises all of us. And there are going to be times where some of us need a little bit more than others. And we have to be okay, because if they improve, then, health improves for everybody. And it becomes less costly overall, even if it's a purely economic decision. If we raise everybody's health, we will actually save more money individually. So
save a ton of money.
Yeah. Well, I really appreciate it. Thanks for inviting me to do this.
Well, Dan, thanks for joining me in this episode, and just keep doing what you're doing to train the future health practitioners to better our communities and help us to age well.
Same to you, brother. All right. Take care. Thanks so much.
Thank you for listening. I hope you benefited from today's podcast. And until next time, keep aging well.